I'm sorry, I apologize for not having allowing our physician delegates to pose a question. We really feel sorry for that. And from one of the organizers, I'm very time conscious, and we're trying to end the conference in a timely fashion. So please pardon for that. I'm indeed honored and privileged to be here with all of you during this centennial celebrations of Sri Sathya Sai Baba and another landmark event being the World Heart Federation celebrating their 25th anniversary here, two landmark events in the holy precincts of Prashanti and Nilayam. We are all indeed very fortunate to be here. We're all blessed. The topic for my presentation today is stress and heart disease. Is it a fact or a fiction? Is it based upon objective facts or something based upon anecdotes and lay press reports? And the reason I chose this topic was twofold. I do not have any disclosures. As a part of the CME committee member, I said that I don't have any disclosures from financial point of view, but I have one disclosure to make. You all heard that Dr. Krishna Rao is one of the organizers and all that. It all goes to Sri Swami. It is the one who is the source and inspiration for the whole thing to happening here today. He's Sri Sathya Sai Baba. And it is not me or somebody else doing this. Stress and heart disease, another reason why I chose this topic is Sathya Sai Baba in one of the previous one of the discourses, he said that hurry, worry, curry being the root cause for heart diseases. And this concept is not something new. It, in fact, goes back to mid-18th century when William Heberden, if you heard the history of cardiology, who coined the term angina, has said that angina is caused by disturbance of the mind. Around the same time, rising death rates from heart disease were attributed to great mental strain and hurried excitement that was published in one of the news articles in one of the Times magazine. Following that, subsequent to that, Hans Selye, the author of the Great Adaptation Syndrome or Great Stress Syndrome, concluded that at the end of a life under stress was a kind of premature aging due to wear and tear. In fact, if you Google an astounding 1.5 million articles, you will come across between linking stress and heart disease. The stress has become an integral part of life. Who doesn't have stress? There are a number of reasons. We are adding more and more stress factors in our lives. The simple reason could be just based upon your mindset to be perfect, mindset to be something, I want to achieve something. I want to get wealth, or it could be position or whatever it is. It all could be in the mindset. Could be something to life events, could be something very trivial as daily hassles in life, or it could be something more serious such as diagnosis of some serious disease in that family member or some losing someone you love. On the top of all this, we are adding technological factors to that. We are addicted to the cell phones and all this. The social media is adding to that. Dr. Ratnagar said this morning about the social media and its impact. And lifestyle factors also, inactivity, smoking, diabetes, smoking, alcoholism, and drugs. All these factors are adding to these problems. And their lack of coping skills. We know that the stress paradox is some take stress very lightly, some take it very seriously. The same stress factor could have different impact in different people. Just coming back to the stress in our lives, if you go to our part of the northern eastern part of the United States, early in the morning, when you get up in the morning, you were trying to rush in to go to the hospital to work, and you see that your car is submerged in the snow and trying to dig it out, and you're rushing to get to the hospital. That could be a stress factor. As a cardiologist, I see patients on a daily basis in the emergency department, 1 or 2 patients either having heart attack, MI, or sudden cardiac death related to shoveling snow. That's not uncommon at all. It's for 6 months it goes on. If you go to the western part of the United States, they have their own share of problems. They have wildfires, earthquakes. For example, during 1994, when earthquake struck Los Angeles, there was 5-fold increase in the incidence of sudden cardiac death based upon stress factors, being the stress trigger, not related to the actual physical harm caused by the earthquake itself. Coming to the pathophysiological aspects of stress and heart disease, there are 2 components to it, either emotional or physical stress due to either, most of the times, negative emotions. Sometimes it will be positive. That's why the equanimity is important. Emotional or physical stress, calling surgery, we have seen some post-op patients having stress-induced cardiomyopathy, medications, intoxication, drug withdrawal. In patients who have predisposing factors such as female gender, postmenopausal state, underlying psychiatric illnesses like schizophrenia, anxiety, panic attacks, diabetes, COPD, so much so and so on. They all trigger the cascade of events by stimulating the hypothalamus and limbic system, the link and the adrenal axis, leading to outpouring of catecholamines and other, like, such as neuropeptides, causing either direct damage to the LV or indirectly by causing endothelial damage, coronary vessel spasm, and spontaneous coronary artery dissection. And in terms of the chronic stress, we all know that chronic stress leads to, as Dr. V. Mohan and Dr. Venkatam, they alluded to you, diabetes, hypertension, they're all related to partly to stress and our other social factors. That all these factors could ultimately lead to unhealthy, they can foster unhealthy behaviors such as overeating, smoking, physical inactivity. They all lead to increased plaque burden and causing platelet hyperreactivity and vasospasm, that pride of recipe for having a heart attack or sudden cardiac death. One fact is that females are much more prone for stress in the heart. As you could see this from graphic, as many as 90% tend to be females, unfortunately. Again, as I explained before, there's a stress paradox because we take stress in a different levels. I would like to go over some classic case examples illustrating what I said before. There are three well-established entities: Takotsubo syndrome or broken heart syndrome, coronary artery spasm, and spontaneous coronary artery dissection, well proven beyond doubt that they're caused by stress. The first case of a 55-year-old female with no traditional risk factors came to the emergency with chest pain and new onset heart failure. It was triggered by a simple event like she had an altercation with a neighbor about her dog, which was unleashed and caused some nuisance in the neighborhood. That was the triggering factor. She came to the emergency. She had classic STEMI anti-wall by EKG. Cardiac cath showed normal coronary arteries, and she was found to be extremely tachycardic and hypertensive. As a part of the protocol, we ruled out pheochromocytoma. And here is the baseline echocardiogram showing hyperdynamic basal portion of the left ventricle and completely ballooned out apex. The good news is that a few weeks later, completely normalized. So basically, it's a classic case of broken heart syndrome, as the name implies. The apical portion of the LV is completely ballooned out. The next case is a 69-year-old Hispanic female, some risk factor for CAD, came to the emergency after being immigrated to the United States for the first time and with a large family. She came to the emergency with several times with chest pain. First time because she had social and language barriers, so many other stress factors which she was going through. Her symptoms were not taken very seriously. Initially, like atypical chest pain, came second time, anxiety. Third time, let's do some other stress test was done, mild apical ischemia. The fourth time, let's observe in the hospital. And here what we find. This time, after fourth attempt to come into the hospital, she was in emergency. I was called in the middle of the night with chest pain. EKG was sent by my cardiology fellow. Here is the EKG on the left-hand panel, tombstone S elevation. All over the clue here is coronary artery spasm because it's not subtended to any particular coronary territory. As you could see, there is ST elevation in the precordial leads and the lateral leads, and there are some inferior wall changes also. And to confirm our diagnosis, she was given nitroglycerin, and you can see that completely normalized EKG. And she had a stormy course for 3 weeks, requiring all kinds of medications. In fact, I had to call Dr. Masseri in Italy to obtain fosfatidil, a rho kinase inhibitor, as a last resort. In the meantime, we thought, so many because of psychiatric factors, we thought psychiatric counseling was done. And fortunately, she has done well for 15 years. And eventually, she died of not a cardiac event, but at the age of ripe age of 87 due to dementia. So next one is a social nightmare. A 45-year-old female with some risk factor for CAD, with a very non-compliance with medical therapies and follow-ups, came to the emergency with chest pain. She left diagnosed medical advice without getting any testing done, then came to the hospital after stopping all the medications because of hypertensive emergency. Then she came back with a STEMI and inferior wall cardiac cath showed spontaneous coronary artery dissection, which was stented because she had refractory spasm. We couldn't relieve it with standard medications. And then she came back again. She moved to a different city, divorced, lost insurance, no medication, stopped antiplatelet therapy, came with anti-OMI, and went on to cardiac arrest. And then here you go. You can see the cardiac cath showed baseline. You can see on the left-hand panel, there's intense coronary artery spasm in the proximal area of the coronary artery, and you can see following intracoronary nitroglycerin completely relieved. Similarly, multiple territories at the same time. How often you have seen that? We have LAD, proximal LAD spasm again, completely relieved after nitroglycerin therapy. And she had a very, unfortunately, she had cardiogenic shock and multiple times CPR and was placed on ECMO, but we could not save her. Unfortunately, this is an unfortunate story here. That's how much social factors can contribute to all these factors. Next one, we talked about, Ratnagaragar said that some cardiac surgeon dropping dead in the OR. Here is an interventional cardiologist spending 12 hours in the cath lab every day. No risk factors, mild hyperlipidemia, well treated, GERD symptoms, classic physician scenario. Some of us don't even have a PCP. Those who have PCP, we don't see them. And then his procrastination is an important criteria for physicians. He had chest epigastric discomfort. He's known to have GERD. He thought he's having GERD again. So here is the EKG. Then he said he talked to the colleague and we did an EKG. You can see subtle ST elevation of the lateral leads, and you can see the EKG showing distal LAD occlusion. By looking at the angiogram, you know that it's not standard classic atherosclerotic plaque. It is either spasm or like spontaneous coronary dissection. You can see the echo at the baseline. There's apical wall motion abnormality consistent with LAD occlusion, and few weeks later, completely normalized. The SCAD has healed. The final case, 58-year-old female with anxiety and panic attacks came with chest pain and with the background story of family member being diagnosed with some serious disease. And you can see the EKG showed lateral ST segment elevation and went on to have a coronary angiogram. You can see on the left-hand panel, there's a lesion involving the obtuse muscle artery. Things are not always as they seem. You could conclude that it could be atherosclerotic disease, or it could be intense spasm, or spontaneous coronary dissection. How would you know? We try to put a guide wire, won't pass through it. Then we know that it is SCAD. We had the capability of doing optical coherence tomography, as you could see on the right-hand panel. The top left, normal coronary artery, but the rest of them showing intimal tear and interluminal hematoma causing compression of the LAD, compression of the obtuse muscle artery causing lateral MI. And the same patient, later on, 1 year later, came with chest pain because of the previous history. In fact, this patient had SCAD involving obtuse muscular diagonals at different times. This time we thought we'll proceed to cath, and you can see on the right-hand panel, the OM SCAD is completely healed. The difference I would like to have is interesting in the sense that the patient, we're fortunate to have Kylie here. Kylie, I would like to come on to the podium just to briefly describe as to what changed in your life that made the difference. You could see that repeat coronary angiogram 1 year later showed complete healing of the SCAD. And Kylie would like to speak about. Kylie has one of the times I said, Kylie, I'm doing this conference, and she jumped into this and she like, go ahead, Kylie.
Okay. Sairam. First, I would like to thank Dr. Rao and his cardiac team. Without their skill and dedication, I would not be here today. Basically, he just said, don't let that happen again. You won't survive. As a result, I had to make some changes to my life. I had to eliminate much stress as I could. So I walk a lot, and I spend a lot of time reading and meditating on the goodness of God. I've lost some weight. I'm more involved with my church, and I've joined Bible study to learn more about God and about my faith. Growing closer to God has given me a peace that passes all understanding. My life has now changed from one of worry and stress to one of acceptance and surrender. My focus now is to share God's love and peace with those around me, and to be kind, to appreciate nature and creation, and to walk humbly and to serve others. Saram.
Thank you, Kylie, for coming all the way to India and be with us today. We really appreciate you. Just 5 key takeaway messages from my talk. Stress-causing heart disease is real, not fictional anymore. Acute stress could lead to the diseases I described, Takotsubo syndrome, SCAD, and coronary spasm. The stress paradox explains why the same stress would have different response in different individuals. And low level of stress may be cardioprotective. We all need to have some exposure. If I didn't give presentation in the past, I won't be able to stand here in front of you. Like, you need to have some low level of stress so that when the time comes, you could be prepared for it. Prognosis, the good news is prognosis is excellent with the appropriate management strategies. Again, in fact, we have several talks planned tomorrow. I would not go into the details because of the time constraints. Basically, exercise. The one thing is, even the elite athletes, in between their breaks, they take meditation and yoga. They think that it enhances their performance. And nothing like getting into the nature. The best antidote for stress-induced cardiac disease is to be in nature and just take a walk in. This is the autumn in northern eastern part of our country. I showed you the snow and all the thing, beautiful at this time of the year. And also, if you happen to be in here, walking on the Chitravati banks early in the morning, listening to the Suprabhatam could be as tranquilizing as it could be. Thank you very much for your attention.
Thank you, sir. Your insights has given us a deeper understanding of